Hello everybody. So for this video specifically today, we're going to be discussing about the cuboid syndrome. So what is the cuboid syndrome? It is a lateral midfoot problem caused by the joint incongruency as a result of a displaced, locked or dropped cuboid after an injury. In terms of the cuboid bone, it is able to rotate about 25 degrees during eversion, and part of its job is to help stabilize the forefoot and help with force transfer. The cuboid bone can actually facilitate load transfer during the gait cycle from the lateral to the medial aspect. It can also be seen as a pulley as well, as the peroneal tendon actually slings around the lateral and the plantar aspect of the midfoot around the bone before inserting to the plantar aspect of the foot to the medial cuneiform. And some of the other intrinsic stabilizers actually include the dorsal plantar cuboid navicular and cuboid metatarsal ligaments, and also the wedge-shaped fibroadipose labra within the CC joint and also the cuboid metatarsal joint. In terms of the mechanics of injury, the problem can actually occur after an ankle sprain, so in this case plantar flexion and inversion. The forceful contraction or the forceful reflex contraction of the peroneal tendon or the peroneal muscle exerts pressure to the bone, causing it to be displaced. In addition to that as well, overuse syndrome can also be a problem. In terms of the etiology, it actually includes the CC joint incongruency, impaired peroneal longus function that actually affects the stability. In addition to that, the peroneal tendinopathy and also damage to the CN and the CM ligament. As you can see, there are actually risk factors that are actually associated and also contribute to the problem. So therefore, in order for us to mitigate the injury, we must take care of these risk factors. In terms of the population that may be more affected by the problem, ballet dancers is actually one of them. So secondary to the hypermobility problem, the continuous dorsiflexion and plantar flexion changes to the moment arm, repeated change of force actually predispose them to the cuboid problem. In addition, basketball players or any other sport that has a high demand for lateral propulsion type of movements can also predispose them also to the problem. In terms of the clinical presentation, the patient may actually experience pain in the lateral aspect of the foot that actually runs and diffuses across the 4th and 5th metatarsal. Also, they may have trouble with weight bearing. They may also demonstrate an atagic gait. In addition, the loss of range of motion and excess eversion and pronation. So it is important to also look for differential diagnosis as well. So never forget the fracture. So in this case, the Ottawa ankle rule can be very helpful. Others actually include gout, Lisfranc injury, lateral plantar nerve or sural nerve entrapment, ankle impingement, and peroneal tendinopathy. In terms of assessment, the clinician may check for the PROM, and joint play may be problematic for the patient, and also resisted isometric eversion may also elicit the pain. Other special tests include the mid-tarsal supination test and the mid-tarsal adduction test. Some of the treatment may include the cuboid whip technique, pronation swing manipulation, taping, and it is also very important to address the deficits of the hip, knee and ankle relationship. And lastly, the risk factors as discussed. If you haven't done so, please be sure to check out our other videos in the education discussion series. Again, thank you very much for all of your time. Be sure to like and subscribe for more.